Let's get started. So this is long-acting buprenorphine 2025 updates. That's me. Not much has changed. I don't have any disclosures. All these medications are FDA approved for the treatment of OUD. I work primarily in outpatient, doing the IOP with our very own Laura Lander here. Now triple boarded in general psych, addiction medicine, and addiction psych. WVC, I'm still doing that. Became the Region 5 alternate director. It's kind of cool. But anyways, moving on. This might be, I might have to be kind of quick with this since we have a case and this is mildly large subject. So we're going to talk about considering medication options for opioid use disorder in general. We'll discuss the various long-acting formulations of buprenorphine, including the 2025 Sublocade changes, labeling changes, provide some clinical pearls and observations that we've gathered over the last, 4 years of using mainly Sublocade and now Brixadi here. My personal goals are to, one, minimize filler words. So if you get bored with the presentation, sometimes what I will do is start counting how many times people say or like or whatever. So you can try doing that if you get really bored with the subject and let me know how many I do. From this point on, I'll try not to say any. And I'll also try not to curse while I record. I have to always remember that this ends up on YouTube, so I'm not going to say anything. Once we stop recording, then all bets are off. So medication-assisted treatment / medications for opioid use disorder. Again, it's the gold standard of treatment. Everybody says you should use them. There's 3 that are approved: methadone, bup, and naltrexone. What are we doing this for? The main reasons are because we don't want people to die. There, Bruce, I'm sorry. The main goals are we don't want anyone to die. We don't want anybody to get sick if we can avoid it. We don't want overdoses, and we of course want to increase people's quality of life when they're on medicines, not just keep them strung out on medicines or what have you. What if we could use these long-acting injectable or / implantable buprenorphine? So theoretically, before we even had access to these things, what are the benefits that you could foresee? So one, eliminating diversion. So if you already have a shot in your system, you can't pull it out and give it to somebody else, which is nice. There's no risk of IV use, so it's not really diverted in that way. You can avoid taking something daily. Smoother course of taking it / withdrawal, ? Depends. More accepted, there's an I see copy. More accepted, less stigma overall. The ultimate opioid addiction cure, ? That'd be nice. Some downsides we could foresee before and we foresee now are, one, the expense of it. So these shots are generally $1,700, $1,800 a piece. With insurance, typically insurance covers it, but if you lose insurance, we have to use grants, we have to do things like that. Side effects and injection reluctance, so people do not always like to take a shot. Talk more about this. Adherence to shots and visits, so not just getting the shot, but actually showing up to your appointments, which we'll talk about. Difficulty obtaining and administering. So the administering part is quite frankly not that difficult, but sometimes the actually getting it to your clinic to administer it can be quite troublesome. Another concern is heavily advertised by Big Pharma, which I'll mention who sells all these. What about also a false sense of security and stability? So the idea that when you're on the shot, you may let your guard down a bit in terms of your sobriety. So what are the options that we have? So we'll talk about this in passing, but Probufene, this was made by Titan Pharmaceuticals. It was actually marketed by Braeburn, who you'll see them again. It was approved in 2016, removed from the market in 2020. So this was the injection, which we'll talk about briefly. Who knows if this may show up sometime again in the future as an option or something like it. Sublocade is the one that probably most of us are pretty familiar with. This is made by Indivior, formerly Reckitt. These are the same people that actually came up with Suboxone / Subutex in the early 2000s. So they are the ones that do Sublocade. They also do Opvi, which is the overdose reversal agent, the option that you have other than Narcan. So it's Nalmefene for what it's worth. This was approved in 2017, and now we have this updated labeling as of February of this year. So we'll talk about that towards the end of the talk. Brixadi, we have now had this for a couple years. So this is by Braeburn Pharmaceuticals. This is approved in May of 2023. It's actually been given in Europe since January of 2019. And you may, if you're reading about things, it's called Buvidal in other countries, which we'll bring up again. But Brixadi here since 2023, Buvidal elsewhere since 2019. And a passing mention, it's not a buprenorphine, but we still have Vivitrol, of course. This is XR naltrexone. This is Alkermes. One of the reasons I bring up these names is if you go to any conference, what are usually the three that are sponsoring the most things, the most tables and such is Indivior, Braeburn, and Alkermes. For better or worse, they're present. They are advertising this stuff. So Alkermes, Braeburn, Indivior. You don't really see Titan anymore. Anyways, what about probuphine? Very briefly, these were rods that you'd place in someone's arm. You had to give it to people 16 and older, which is the case with all forms of buprenorphine. So you have to be 16 or older per FDA to receive it. You will occasionally see people under the age of 16 receive bup. 4 rods in the arm. Healthcare providers had to have basically procedural competency to administer. So you had to be registered to give these. I don't believe we ever gave them here. I don't know if anyone on the call ever has, but it's kind of gone the way of the dough, unfortunately. This is what it looked like. A little bit like almost a Nexplanon implant, if anyone's familiar with that for birth control, but you put it in the arm and it was a little trickier to remove. You could only use one arm for 6 months and then switch back to the other arm for 6 months, 12 months in total. Anyways, you don't see it anymore. Who knows if it might make a comeback at some point, so it bears mentioning. Sublocade, this is one that pretty much everyone should be familiar with. It's an injectable subcutaneous buprenorphine solution. It has to be refrigerated. It's indicated for patients with moderate to severe opioid use disorder. So technically, if someone's mild, they really shouldn't be getting any of these. This, it's not may change, it is actually has changed. So originally you had to be on sublingual, whether it was films or tabs, for 7 days before you could start Sublocade. So that was a big point of not really contention, but it was troublesome. It was tricky to get people on Sublocade. Shots of 300 or 100 used to be placed in only the abdomen, only for the first 8 years, and this is actually changed now. So I put only for the first 8 years now. Year 8, we can do other places. Indefinite length of treatment with Sublocade for OUD. There are people that have been on it since it was released commercially 7, 8 years ago, which is pretty cool. Being marketed by Indivior to various entities, including the legal system for maintenance during incarceration. So you will see people that are incarcerated end up on Sublocade, and people that are being given it prior to release from prison, and drug courts, question mark. I've seen it there. Indications for Sublocade, again, moderate to severe opioid use disorder, 7 days, which has changed. It's supposed to be used as part of a complete treatment plan that includes counseling and psychosocial support, just like we do. The equivalent's always been a bit fuzzy, but it's between 8 to 24 milligrams. So what we've seen time and time again with these XRs is there's never really a direct correlation from the shot to the film. So it really varies from person to person. After steady state has been achieved, so this is over about 4 or 5, 6 months of getting shots, that when you discontinue Sublocade, you can have a detectable plasma levels of buprenorphine for 12 months or longer. So you've received a shot for say 6 months, and then you don't give someone another shot for a year, and guess what? You still may see detectable levels of buprenorphine in their system. This is both a good thing and potentially a curse, in that we have had individuals, say someone that's in not drug court, but something of that nature, probation, and they've discontinued these shots, and yet they continue to test positive, and you have to write a letter to describe why, and it can be a bit interesting, but a pro and potentially a con for some. The administration initially was for subcutaneous only. This has changed. A big key for either of these shots, though, is you do not want to administer them intravenously, so that could kill somebody pretty quickly. If you put it in the muscle, so if you go too deep, that is bad as well, or intradermally, so if you go too shallow, too superficial, like a PPD shot, for those who are familiar, those can all be bad. So into the vein, you could kill somebody, how viscous these are. Put it into the muscle, that could damage the muscle. If you put it in the skin, that's probably one of the reasons why we saw a lot of injection site issues where people would have like a wound develop from the shot being given too superficially. Only us should administer them. Surprise, surprise. This still holds true that really there's a minimum of 26 days between doses. We typically give every 28 days in clinic just to keep them more or less on a weekly schedule. The initiation of of Sublocade as the first Bupe product hadn't been studied. So the idea at first was you wanted this oral induction, the 7 day, 1 week kind of ramp up period before you could give someone a shot. Now, with that being said, even though that was part of the FDA labeling, people were giving Sublocade a lot quicker. So they were giving it after, say, 1 or 2 days or just one dose of sublingual. That was done often in hospital settings. In Canada, I've heard many times where what is it, Healthcare Canada or whatever it is, they would approve it pretty quickly. So you'd hear about people getting Sublocade pretty rapidly. So this is where Sublocade was given and still the manner in which it is given. So it is a syringe. You have to draw it up. You have to go in at a 45-degree angle. Again, you're trying to put it in a subcutaneous area. You're not trying to go too deep. You're not trying to go too shallow. But in general, we're sticking with the belly for a long time. The volume solution, 0.5 mLs for 100 milligrams, 1.5 for the 300. Dosing of Sublocade, we're going to go over this kind of quickly. It has always been 300 milligrams for the first 2 months, followed by a maintenance dose of 100. With that being said, if somebody does not do well lowering to 100, you can keep people at 300. And we've had a lot more success just having insurances agree to keep someone on 300. The cost is actually exactly the same between the 300 and 100, so that doesn't really matter. But in theory, it was 300, 300, 100, or even some people that were a bit more opioid naive, or I should say their tolerance wasn't as high, they could do 300, 100, 100. But oftentimes, clinically, you'll see people on 300, 300, 300, 300, 300, just definitely. Adverse reactions, as you can imagine, similar things to other forms of buprenorphine, so constipation, potential for elevated LFTs. You would see injection site reactions, certainly with Sublocade, and likely in part due to how you have to administer the shot at an angle, which is a bit tricky. So post-marketing problems, we saw these before: abscesses, ulceration, necrosis. That was a problem. Likelihood of these reactions happening, of course, is more likely to the shot being given improperly. All right, some keys with Sublocade. We use in patients moderate to higher buprenorphine doses in general. It should not be started immediately, or at least it shouldn't. You were supposed to be on this 7 days of sublingual. You will still often see people that are on this ramp up period before going over. Only monthly versions, 2 strengths available, 300 and 100. If you wonder why there wasn't a 200 milligram shot, I've asked them that directly, and they said it didn't really show a significant difference between the 300 and 100, so they just did away with it basically. Abdomen only, injection site reactions can occur. Does require a REMS program, just like Brixadi. So those that are using Sublocade, I'm sure you know that there is a bit of a challenge navigating getting the REMS up and going. Once you do, it tends to not be super difficult, but it's very good to have a good pharmacy that's working with you to understand how to jump through these DEA hoops. Use as a discontinuation treatment has not been thoroughly studied. Theoretically, could be a good option given extended plasma levels after discontinuation. I will say certainly clinically we have used this in this manner, and it can be good, but you're not going to see any giant studies, at least I haven't, of this being used to get people off of sublingual bupe, but we have used it clinically. Cost is about $1,750 a month. Both doses cost the same. So that's Sublocade. As of now, we'll talk more about Sublocade in about 10 minutes. All right, what about Brixadi? Injectable subcutaneous bupe solution, very similar to Sublocade in many ways, was approved in November 2018 and first used in January 2019 in the EU as Buvidal. So you will, if you read your European literature, addiction literature, you may see something about Buvidal back 6, 7 years ago. Same thing as Sublocade, 16 and over. December 2018, originally we could have got it, but basically the FDA chose Sublocade over Brixadi, and there's these complicated exclusivity rights where you could have only one shot, not both. So we were kind of stuck without it for a while. And it wasn't until 2 years ago now where it was fully approved through the FDA. And now it's been nearly 2 years that we've been able to give it to people clinically. So hard to believe Brixadi's been out for 2 years now in the United States. Same indications as Sublocade. No refrigeration required for medication, which is kind of cool. So you do have to refrigerate Sublocade. It has to be in a locked, separate thing, which can actually be an issue with certain clinics trying to just store it in a locked refrigeration device. Brixadi doesn't need that. It just needs to be in a locked cabinet. Big difference between the two. You have these weekly forms and monthly forms available with various dosing. So that is different than what you see with Sublocade. So in terms of what we have monthly, which most people are on monthly, we have 3 doses available. In Europe, they actually have a fourth dose, which is higher, kind of interestingly. I will say that Braeburn is trying to get this dose in the US, so we'll talk about that more. It is placed subcutaneous like Sublocade, but it has always been available to be placed in other areas. So abdomen, thighs, buttocks, and shoulders, although we've been told when we were doing clinical trials with Brixadi that it has a little bit less absorption in the arms for what it's worth. So these are the areas you can give the shot. The shot is a little bit different in terms that you tin up the skin and the injection is 90 degrees straight down. So you're not trying to go in at any angle, basically. You're just going straight in. So it's a little bit simpler. The shot versions that you see, again, the milliliters is smaller. I mentioned with Sublocade, it's 1.5 mLs, which is a pretty decent amount. The most volume in a shot, believe it or not, is in the weekly form at the 32 milligram dose. So it's 0.64 mL. So that's a little bit more than the smallest dose of Sublocade. In terms of the monthly has a different matrix that it's stored in. And actually, the strongest version of Brixadi that we have available, 128, is only 0.36 mLs. So it's much less. So it's about fourth as much volume as the highest dose of Sublocade. It's kind of interesting. So the weekly solution, you have between 0.16 mLs to 0.64, and the monthly is 0.18 to 0.36. And I would assume that the 160, when it becomes available, would be somewhere around probably 0.54 mLs, somewhere in there. But we'll see. All right, moving on. Dose comparability and side effects. New patients typically are started on the weekly and then ideally transition to monthly. So the idea with the weekly form is not necessarily to have someone indefinitely on the weekly, although you can do that. In certain subpopulations, you will see the weekly used. The goal of the weekly really was to rapidly initiate somebody on long-acting form. Established people can be immediately proceed to monthly. So this, again, is a bit of a rough estimate, but daily dose of sublingual, so less than 6 or 6 or less, around 8 milligrams. 8 to 10 is 16 or 64. These numbers we found there's always kind of a fudge factor, as it were, where it just doesn't quite line up as much as we'd like it to. So for one person, 96 may feel too strong. For someone else, 128 is just not strong enough, even though their doses can vary. So it's a bit tricky. You do see injection site issues very similar to Sublocade. We have seen once or twice, I think, a necrotic area, but that tends to be a little bit less with Brixadi over Sublocade. I have seen bruising with Brixadi, so you can hit sore spots with people. Little bit into new patients. We won't go on this too much, but part of the reasons for these slides, and you all will have access to them, is just as a reference if you need to go back. And certainly anytime you order these things, you have the packaging, which includes all this too. So it's pretty easy to look and see. But the idea is if someone's not receiving sublingual bupe, is to start them on this weekly shot and get them to a good dose pretty quickly to make sure they tolerate the weekly shot, and then quickly get them into the monthly. So oftentimes the first dose of Brixadi weekly is 16, then you give a booster of 8 within a few days, and then you go to 24. And from the 24 dose, you can actually go up to the higher doses. So if somebody is tolerating 24 fine, but you try 32 and it's too much, you can just jump to the 96 monthly, or if they're doing well at 32, you can go to 128. But again, as I said, very rarely do you see people stay on weekly Brixadi for a while. Most people are pretty rapidly going from sublingual to the monthly forms, just like Sublocade. All right, discontinuation of Brixadi. This is being actively studied within the CTN 100 trial, so we're actually comparing versus SL-Bup, XR naltrexone, kind of its own thing, but it doesn't really matter. There is no maximum recommended duration of maintenance treatment, so you could theoretically have somebody be on Brixadi for years and years and years. Within the trials, we've had people take it for about 3 years nonstop in total and do perfectly fine. Again, Sublocade, because it's been around a little bit longer, 6, 7 years, 8 years. Some people that have been on Sublocade for that long and doing fine. If it is discontinued, in theory, because it is extended release, you should continue to monitor somebody. And this goes for either one. So I mentioned this can be a good discontinuation medicine, but in theory, let's say somebody has been on the medicine doing fine, you stop it. You don't want to get in the habit of saying, okay, a month later, shot's going to be out of your system. If you get through that period, fine, you're fine. When in reality, again, it's going to slowly taper off out of someone's system over the course of months. You really should keep an eye on them for 4, 5, 6 months, I would argue, when you discontinue it, if somebody's been on it for a while. So you reach a steady state, which is 4 weeks for the weekly form and 4 months for the monthly form. So you honestly do want to give Brixadi probably 3 or 4 months of just continuous shots to really see where somebody is stability wise on it. It will last in your system quite a while. Got to tell my brother that I'm busy doing stuff right now. Um, it will stay in your system for up to a month when you discontinue the weekly. And according to this, 4 months for the Brixadi. I have seen people, we just had somebody I saw last week in the study, and they last received their shot in December of last year. So this is August, and they still have levels that are at least showing up on a drug screen. We had sent it for confirmation, and it's not appearing. So it's enough to trigger the screen, but the confirmation, it's below the cutoff level. So there must be a little bit in there, but not much. So again, we're talking 7 or 8 months since their last shot with Brixadi. So it's there. Keep moving on. Whoops. Keys with Brixadi can be used in patients on various buprenorphine doses, given that you have these available different doses. Just need one test dose of SL buprenorphine to initiate, not 1 week. However, that now has changed with Sublocade. Weekly and monthly forms, which this is unique to Brixadi. So this gives you a little bit more flexibility, but the goal is typically to have somebody go to monthly as opposed to staying on the weekly. Can be placed in various sites. It always has and hopefully always will. It does require the REMS program just the same as Sublocade, which can be a bit challenging. What you generally see if you're using it for Medicaid is they will typically only approve 96 milligrams as a max starting dose. So that's equivalent to about 16-ish milligrams a day sublingual. But they will pretty rapidly allow for an increase to 128. And again, we don't have the 160 yet, but I hope we might in the next couple of years. Cost of the shots is very comparable to Sublocades, maybe $50, $100 cheaper, but they're more or less a wash. They're expensive. So these are the big changes for Sublocade. So as of February of this year. So these are just the highlights. So One is a rapid initiation protocol. So you can give Sublocade after one dose of some sublingual or transmucosal, sublingual, whatever, of buprenorphine. So as opposed to 7 days. So you can give it to somebody, give somebody a test film, test tab, give them the shot, and you're good. 1 hour of observation before you give the shot. So pretty quickly. The other big thing which is identical to Brixadi, is now you can use, of course, the abdomen, which has always been there, but you can use thighs, buttocks, back of upper arm. So do these sites sound familiar? So basically, the changes were to make it reflect very similar to what Brixadi was doing. So Sublocade and Brixadi, it's more or less a wash now in terms of initiation, except that you do not have weekly forms of Sublocade. All right, a little bit more. So in theory, hopeful clinical impact, improve patient adherence. So getting rid of this 7 day ramp up to do the shot, that you'd lose some people at that point. So in theory, that should hopefully help with adherence, and also a little bit more flexibility and comfort. So more site options, especially if the abdomen is non-preferred. So we've had people that just didn't want to get a shot in their belly, and that was a big turn off from Sublocade. Also, in theory, is a faster therapeutic blood levels of buprenorphine. So the faster the levels, less likelihood of relapses. So if you get somebody on the shot earlier, in theory, that's going to be better than putting them on the films for a while. Anyways, supporting evidence for these changes, there was a non-inferiority study that was sponsored by Indivior. This is it if you want to look it up. But the idea was they got about 730 people. They did an analysis, and most of these people actually were using fentanyl. So they were sick patients prior to. What they saw was with the rapid induction, you had a greater likelihood of retention at the second injection. So 66% as opposed to 54. Notice that none of these things are perfect, right? You will have a drop off of people who only get one shot, never get a second shot. And of course, we know that's true with Vivitrol in particular, is that there's a huge drop off from getting that first shot to ever getting a second shot. But that is the case even in things like Sublocade and Brixadi. So of note, there were really no major safety changes or to efficacy changes with how you change the initiation and the new injection site. So it worked out to be about the same. Common adverse reactions are the same as it's always been. The REMS program has not changed. So REMS, just as it was before with Sublocade and Brixadi, it remains. So dealing with REMS, it really is just how the FDA is saying you can go about starting the shot and where you can put the shot once you've done so. All right, we'll briefly go into this. This was something we brought up last year, but keep in mind that in the monthly forms of Brixadi and the monthly doses of Sublocade, there is this solvent carrier NMP, which is a potential teratogen. Weekly formulations of Brixadi use a different carrier, so it's ethanol, which this amount of ethanol probably unlikely to show up on a drug test. However, in theory, it's possible, especially if you have an extremely low cutoff point. So I would just say that if you have somebody who's never had alcohol in their system and you put them on weekly Brixadi and now they may have ETG, ETS, you may want to think about whether the ethanol as part of the shot could contribute to that. So there are studies that have been done on the safety of weekly Brixadi throughout pregnancy. So just giving the weekly shot over and over again because you eliminate this NMP. There are no controlled trials that I'm aware of monthly Brixadi or Sublocade during pregnancy. However, there's lots of individual cases and in-case reports of success. So we have done this clinically where we've given someone monthly Sublocade or monthly Brixadi throughout pregnancy, which contains NMP, and things have been okay. I'm not saying you should, but it's been done. Generally, if someone is on one of these shots and they become pregnant, the gold standard of medical care is to switch somebody to maintenance with SL-Bup, whether it's with or without naloxone, so Subutex or Suboxone. Comparing formulations, and so this is really going into the weeds. I was given this about a year ago, but little differences between Sublocade and Buvidol, which again, that's the European form versus /Brixadi. You will see the doses that there are more Dosing options, how long it takes, the steady state you might see, what you'll often see with the Sublocade is it's probably a bit stronger in terms of the amount that's floating around at steady state as opposed to 128. Again, that is one of the ideas of why we're missing a 160 milligram here, is it could make it slightly more comparable between. The amount of NMP, though, also varies. So you will see, again, the carrier, if you're worried about just the average, the total amount that's present, 278 and 833 of NMP, respectively, in 300 milligram shots. None in the weekly form. It's ethanol instead, and much less in the monthly form of Brixadi, for what it's worth. Okay. Lastly, clinical pearls and observations. So these are some things, just having used Brixadi now for going on 5 years, because initially we used it for within study purposes in the last 2 years clinically, and then Sublocade now we've used here for 4 years, I believe. Anyways, person-to-person preference between the two medications vary widely. So some people like their Sublocade, some people like their Brixadi. They're both pretty comparable. Oftentimes, when first initiating the LAIs, additional sublingual buprenorphine is required for all versions and for formulations. There should be an R in there. So you often will early on still need to give some people a little bit of sublingual, which I think actually that can help a bit with the trust factor too, and just helping people realize that you do want to make this work and you're willing to work through it if they don't tolerate the shots as well as they expect for whatever reason. Monthly Brixadi has marginally less injection site issues, likely due to less medication volume and generally simpler administration, in my opinion. So I do think that Brixadi, it's harder to mess up the shot itself. You're generally not going to see the necrotic areas that you may see on Sublocade. Honestly, if you're trained well in giving both, you're probably not going to see too many injection site reactions either way, unless you have some freak occurrence. Sublocade does last longer in the system and has a longer tail after multiple shots. So it does, in theory, last a bit longer than Brixadi. It's probably slightly stronger, apples to apples, if you're trying to do that, Sublocade to Brixadi. Again, if we get this 160 milligram dose of Brixadi, it could be a bit more comparable to the Sublocade, but there are times where like for instance, I saw somebody today who's been on 128 at Brixadi for 4 or 5 months, and they're still towards the end of the month feeling a little not great. So what we're going to try to do, and we've done this before for other people, is switch them to Sublocade 300. So they've been on 128 Brixadi, doesn't seem to last quite as long as they wanted to. We're going to switch them to Sublocade and 300 and see what happens. Specialty pharmacies for REMS versus local pharmacies, it must be delivered to clinics, so you do have to keep this in mind, whether you're using like a mail order specialty pharmacy. Sometimes the insurance means that you have to use this versus a local pharmacy, specialty pharmacy that's willing to deliver it. So that can be a bit tricky. More pearls. Some people do get very scared to get an injection, especially if they have an IV use history. So this can be very triggering. So not everybody should be forced, definitely should never be forced to go on a shot. But we have had people that, for whatever reason, very valid reason, is they just don't want a shot, period. They've had too many negative experiences injecting, and they say, I'm not doing a shot. Doesn't matter how big or small the needle is. Adherence to frequent visits can be a challenge given the nature of monthly shots. So especially on the monthly shots, not everybody wants to show up to come to their weekly visit, and you don't have quite as much leverage, as it were, to have people come in. This can be a interesting clinical discussion is, do we take somebody off the monthly, say Sublocade, and have them go back to weekly sublingual because they're not showing up to their visits? Ethically, very gray. Personally, I would rather people just stay on the shots, and we try to figure out other ways to get them to come in for their visits. But it's interesting trying to work through it. I'm sure you all have experienced that. You have seen some increased acceptance by the community and law enforcement over the standard SL version. So I'd say there's less stigma in general. So I think if nothing else, these shots being available has lowered the amount of stigma when it comes to being on buprenorphine. So whereas you might hit stone walls about someone being on buprenorphine before a film or a tab, getting somebody on a shot can make a difference. So that's great. Stress maintaining insurance coverage and consider if legal entanglements. So monitoring insurance, and we are in the age right now where a lot of people are worried about maintaining their insurance coverage. If someone suddenly does not have insurance to cover these, no one is going to out of pocket be able to pay for $1,700 shot. Okay. It is not the best choice for everyone, these shots, but when these LAIs work, they generally work very well. So not everybody should be on the shots, but people that do decide to get on them and stick with it for a while, they generally do pretty good. So there's definitely a place clinically for these. They are not the end all be all. They should never replace all films or tabs or whatever it might be. But it is nice to have this option available, which is great. All right. So in conclusion, MOUD remains the gold standard of medical care of OUD and represents the most effective treatment. We have these long-acting forms which offer some advantages. Sublocade and Brixadi are available and insurance will pay. There are these recent labeling changes to Sublocade, which gives us a little bit more flexibility, which is good. Caution to use in pregnancy, but not absolutely contraindicated, so we can use them. The weekly Brixadi theoretically would be the safest version. These medications are not a cure for OUD, but they offer an appealing choice of MOUD for the right patients and situations. So I would just say always let's continue to be advocates for all effective OUD treatments, whether it's buprenorphine or methadone, lest we forget about that, or naltrexone for the right people. So if anybody has any questions, that was us a few years back. I didn't add any stuff from Hawaii, and I'm sorry I didn't get a chance to add any jokes from my son. Uh, we did that last year, but we had a little bit more information to go through. So I promise I will add something if it's a shorter topic next time. But,
You have a question in the chat.
all
Um,
right.
says, can you discuss the conversion, from switching someone from Sublocade 100 or 300 monthly to a weekly Brixadi?
That's a complicated one. Uh, I would say we never use eight. So the eight weekly of Brixadi is really almost used as just a booster dose. So I've never seen eight used clinically. I would say if you're going from 300 or 100, probably the goal would be either a 32. So that's the strongest dose of weekly. Someone's on 300, I would go to the strongest dose weekly of Brixadi. If someone's on 100, that would be more of a guesswork between either 16 or 24. Personally, I'd probably give somebody a 24 firstly, and then more maintain them at 16. You're generally never going to have anybody maintained on 8. I'll put it that way. So hopefully that's helpful. By the way, I had trouble getting insurance to pay for that. Yeah. Insurance, I would say you definitely want to be proactive anytime that you are making a switch from one to another because the PAs are never going to, they're never going to, a 128 of Brixadi is never going to account for a 300 of Sublocade or whatever it might be. So you're always going to, anytime you change the doses, you're going to have to do a PA, which is unfortunate. So, any other questions? Like how I created a word fofulations instead of
So I have a
formulations.
quick question.
Yeah.
Have you or others seen more incidents of breakthrough withdrawal with Brixadi versus Sublocade?
I think you can a little bit, especially at the end of the month, because it has the shorter half-life. So that is a feather in the cap of Sublocade. I think that it has a little bit of a longer half-life than Brixadi. And if you asked Indivior or you asked Brayburn or whatever, I think everybody would agree that the tail of Sublocade is longer. So just theoretically, it would, you have
What about
greater
like at
128.
well, at induction, like when they first started?
That it tails off even faster.
No, that people have a more need for a greater need for
Oh,
films to cover any withdrawal when they're first starting the medication.
just right out the get-go. I don't know if I've really seen any major differences between the two. I guess in theory it would because with Sublocade it is just more of medicine, especially the 300, and because we've been limited with the 96, the Medicaid generally only wants the 96. So maybe if we were able to do the 128 off the get-go, or again, if someday we get the 160, it may be more comparable, but yeah. So maybe a little bit more with Brigzotti, but it seems about the same. Certainly the tail though at the end of the month, I would say Sublocade almost guaranteed less of a tail or better tail, less chance of that. So neither is perfect. They have their limitations. So other
All
questions? Sorry
right.
if we went case time a little bit.
Oh, no, you're fine. I'm gonna go ahead and switch gears. If anybody goes to have any questions, you can feel free to put them in the chat, where you can shoot me an email, and I can make sure that Dr. Hustead is able to get those and get the answers to you. So at this time, we are going to go ahead and switch to our case presentation. But first, I want everyone to note that our next session will be August 28th, and we're going to have Kristen Antolini. She will be the presenter.